Hi guys, welcome to Plasma. So we are going to discuss the summary of drugs used in hypertension. So first is subclass diuretics, which contains thiazide diuretics, hydrochlorothiazide, and chlorthalidone. So mechanism of action is that they block sodium and chloride transporter, which is present in the renal distal convoluted tubule. Now effects reduces the blood volume. Clinical application is in hypertension and mild heart failure. Now, loop diuretics, for example, furosemide. Mechanism of action is that they block the sodium, potassium, and chloride transporter, that is a symporter present in renal loop of Henle. Effect similar to thiazide diuretics but more effective. Clinical application is in severe hypertension, heart failure. Now, spironolactone, epinephrine. The mechanism of action is that they block aldosterone receptor present in collecting tubule. Their effects, they increase sodium and decrease potassium excretion. Now, the clinical application, aldosteronism plus heart failure plus hypertension. Now, the second subclass is of sympathoplegics, centrally acting sympathoplegics. For example, clonidine and methyl dopa. The mechanism of action is that they activate alpha 2 adrenoceptors. Okay, the effect is that they reduce central sympathetic outflow, reduce norepinephrine release from noradrenergic nerve endings, right? And the clinical application is hypertension. It's clonidine is also used in withdrawal from drug abuse, especially opioids, right? Then third subclass is sympathetic nerve terminal blockers, right? So rezapine, okay. Its mechanism of action is that it blocks VMAT, vesicular amine transporter in noradrenergic nerves and depletes the transmitter stores. and its effect, it reduces all the sympathetic effects, especially the cardiovascular, and reduce blood pressure. Right now, the clinical applications, hypertension, but it is now rarely used. Next, guanethidine and guanadrel. Its mechanism of action, it interferes with amine release and replaces norepinephrine in vesicle. Interferes with amine release and interferes and replaces norepinephrine. Okay, so it replaces norepinephrine in vesicles, and its effects are same as rizapine. Clinical application is in hypertension, but this is also rarely used. Okay. Now we come to the fourth subclass of alpha blockers. Okay, so they include prazosin, terazosin, doxazosin, right? So the mechanism of action is that they selectively block they selectively block the alpha 1 adrenoreceptors, and effects, they prevent sympathetic vasoconstriction, reduce prostatic smooth muscle tone, right? So this can be used in BPH patients also. Now clinical application is in hypertension and BPH. Now coming to beta blockers subclass. Okay, they include metoprolol, carvedilol, nebivolol. Okay, so propranolol is a non-selective prototype of beta blocker. Metoprolol and atenolol are widely used beta 1 selective blockers. So the mechanism of action here is they block beta 1 receptors. Now, carvedilol also blocks alpha receptors, okay, and nebivolol also releases nitric oxide, right? So releases nitric oxide. That is the endothelin derived relaxing factor from endothelin. Okay. Now we come to the subclass of vasodilators. So first is verapamil. Okay, its mechanism of action is that it is a non-selective block L-type calcium channels. Okay, and same with diltiazem. Okay, now effects, it reduces the cardiac rate and output and reduces vascular resistance. Clinical applications are in hypertension, angina, and arrhythmias. Now, nifedipine, amlodipine, and other dihydropyridines. Okay, their mechanism of action is that they block vascular calcium channels, right? more than cardiac calcium channels. Okay. Now their effects, they reduce the vascular resistance, and clinical application includes in hypertension and angina. Now next, hydralazine. Okay, it causes nitric oxide release. This is the mechanism of action, and its effects are that it causes vasodilatation, right? It reduces vascular resistance, and arterioles are more sensitive than veins. Okay, and it produces reflex tachycardia. Clinical application, hypertension. Next, we'll discuss minoxidil. Now, it is a metabolite that opens K plus channels in vascular smooth muscle, and it affects same as hydralazine. Clinical application, hypertension, and it's used to treat hair loss also, right? Now, another subclass, parenteral agents. So, we'll discuss nitroprusside, right? So, its mechanism of action is that it releases nitric oxide, that is again EDRF, endothelin derived relaxing factor, and its effects are it is a powerful vasodilator. Clinical application includes hypertensive emergencies. Okay. Next, we'll talk about phenol. So, its mechanism of action is that it activates the D1 receptors, right? And this is also a powerful vasodilator. Clinical application, hypertensive emergencies. Now, we'll discuss diazoxide. Its mechanism of action is that it opens K plus channels, producing powerful vasodilatation, and now it is only used in hypoglycemia. Okay, this is very important. Next, we'll discuss labetalol. Okay, so labetalol is alpha and beta blocker, right? Alpha plus beta blocker, and it is also a powerful vasodilator. Okay, it's used in hypertensive emergencies, right? Next subclass, we'll move on to angiotensin converting enzyme inhibitors. Okay, ACE inhibitors, right? So we'll discuss captopril. The mechanism of action, as the name suggests, inhibit angiotensin converting enzyme. So yeah, inhibit angiotensin converting enzyme. Okay, the effects include reduce angiotensin level 2 levels. So reduce angiotensin 2 levels, reduce vasoconstriction and aldosterone secretion, right? And increase in bradykinin. Okay, so I'll repeat one more time. Effects are reduced angiotensin 2 levels, reduced vasoconstriction and aldosterone secretion, and increase in bradykinin. The clinical application is in hypertension, okay, heart failure, and diabetes, right? Now, next subclass ARBs, right? So, angiotensin receptor blockers, which include losartan, right? They block the angiotensin 1, angiotensin receptor. Now, the effects are same as ACE inhibitors, but they do not increase bradykinin, right? Same as ACE inhibitors, but there is no increase in bradykinin, right? Clinical applications same in hypertension and heart failure. Now the last, renin inhibitors, right? So here we'll discuss aliskiren. Okay, this is very important. So its mechanism of action is that it inhibits enzyme activity of renin, okay, and its effects, it reduces angiotensin 1 and 2 plus aldosterone, right? It reduces angiotensin 1, 2, and aldosterone. So, clinical application is in hypertension. That's it. Thank you very much.